All right, so we're recording for a review session as requested by the students. It's about 10:03 on 9/21. The topics that were requested were common ECG readings, common medications used for Ionto, pelvic tilt diamond, and then synergy patterns. So let's start with the ECGs. I also wanted to clarify subacute, and okay, we can do that. Good morning, Kiana. I will add acute, subacute, and inpatient for sure. That's an easy one to add. So with ECGs, what was it specifically? I know you said you were talking about common ECG readings. Were you talking about what represents an ischemic pattern versus a muscle injury versus a diseased pattern? Is that what you were talking about when we're talking about ECGs? Or what was it specific about ECGs that you hit? So just to set you a little bit at ease, if you pick on Pete that we're asking. Okay, so yeah, so it's probably looking at the most common of them. So let me bring those up here real quick. So we will go share screen. And we will share document. And let me bring chat back up just so I can read it. So the most common ECGs that we're going to encounter, obviously you have your normal ECG readings. Those typically you're not going to have to, those look like your typical injuries. This is your most common ECG injuries. This is looking at either ischemia injury or infarction. So ischemia meaning that the blood flow is being cut off somewhere. Injury meaning the heart has some sort of an injury to the actual nodes themselves. And then infarction obviously starting to go into that cardiac arrest and everything. So let me also get up a normal ECG so that we can have that as well. So let me grab one of those. Where's my snippet tool? There's my snippet tool. All right, everything's in the way of everything else. How does that happen? There we go. And now I move stuff in the way. It's spoiled having multiple monitors, and just being on one computer monitor throws me off. Okay, so there's kind of our normal ECG reading, right? So we have our P wave going into the Q point, R, and we have our S, and then we have our T wave afterwards. With when you're looking at somebody that's got an ischemic heart, the T wave itself is going to be inverted. Because if you look down here at the normal, the T wave peaks. And when we have anything dealing with a problem, that T wave is actually going to trough instead of peak. So with ischemia, the trough is going to happen rather than the peak. So if you saw that's showing up on an EKG, if the patient is known to have ischemia, well, then there's not much. You're just going to watch it to see if that T wave drops even lower. And if it just sits like it is right now, then that's just kind of where they are. So that's why, when you go into a patient that's on the cardiac wing, you don't have to be an expert at reading the ECG. That's one of the first things you should do is talk to the nurse to make sure they've checked the ECG before you get them out of bed, right? But if you know that they already have some ischemia going on, an inverted T wave is going to be a normal response. So if you have, and again, remember with these questions on the ECGs, you might get one, if that, because we're not supposed to be trained ECG readers. That's the good thing. But if you go in again, you see that the T wave's inverted, and it's a patient, maybe you have a patient that's a total knee replacement, and you go in and you see somebody that's got suddenly a T wave inversion that's indicating ischemia. What do you think your proper response would be for that? So you go in, they're maybe they're in the PACU or something, they're recovering from their knee surgery, and you look at the monitor and you see that T wave is inverted. what do you think your response should be if that's not a normal reading for them? Yeah. Stop treatment. Yeah, alert the nurse first, right? Because maybe something happened and you're not aware of it. It's not in the chart yet or something. And maybe they had an ischemic event coming out of anesthesia. So yeah, first thing, stop. Nope, we're not doing anything right now. Hold on, let me check with your nurse, right? Don't freak out the patient like, oh my God, your T wave is inverted. You're having ischemia. That's going to do wonders for his heart rate, right? Just hold on a second. I got to check with the nurse about something, and get out there and check with their nurse and say, hey, I'm noticing T wave inversions. Can you come check it for me? Right? So anytime we have a T wave inversion that's abnormal, treatment's going to stop. No more treatment. That's the end of it. Boom, we're done. We're going to go get the nurse. Now, if the nurse comes in and says, yeah, that's okay, they're safe for treatment, then one of the things I'm going to do personally as a PTA, even though this isn't part of the question from the boards, is I'm going to document that I noticed an inverted T wave, checked with nurse, and nurse gave clearance for PT. Just because that way I want to make sure that I cover my butt as well. So then we look at injury, right? Somebody's got some sort of an injury to their heart. I actually want to make this a little bit smaller if I can, so I can, there we go. So if you look at that kind of ST area in the regular EKG down here, right? You drop from the R, you drop down into the S trough, and then rise up to the T wave. When you have an injury to the heart, we've got this weird where there's not a real trough between the S and the T. So the S and T, it's called ST elevation. And again, that's going to be pretty prominent because we all know that normal beep and that drop and then the raise. So that should be an easy one to look at. Now, what could be causing injury to the heart? When might this appear when we're working with them in physical therapy? What type of physical therapy might we be doing with them that we might notice injury to the heart specifically? Yeah, aerobic, right? Anytime we get into that aerobic activity. So we get into that aerobic activity, we're challenging that heart. And most of them are going to be on telemetry. The good news is they're going to probably be on pocket telemetry or something like that if we're working with them. So the likelihood of us even noticing the ST elevation is pretty low because they're going to be on telemetry at the nurse's station once we put them on pocket telemetry. But say you're in the room with them and you put them on an upper body ergometer or something that you brought with you, and they're pumping along there, and all of a sudden you see an ST elevation. Well, watch for it, right? Because once could just be that the heart hiccuped. And if the heart hiccups, that happens, or it's what's called an artifact, right? An artifact is where things aren't normal. The same thing with ischemia. If you immediately notice a T wave inversion, watch for a couple of them and make sure that's an actual T wave inversion and not an artifact. Because if you have an artifact and freak the whole floor out, that's not necessarily a good thing. So you want to kind of watch to make sure that it's a steady inversion or a steady elevation so that you've got that. So again, in the case of this, the same thing's going to happen. We stop PT, get the nurse, right? And what do you think is going to cause it more likely to show something to show up on the ECG? Upper body aerobic exercises or lower body aerobic exercises? Yeah, up stuff, right? Anything we're doing up. That's why they talk about patients that are coming out of that cardiac cycle that we may not want to do much more, do much more than body weight activities with them on their upper body for a little while. Because lifting with the upper body it's closer to the heart, it's going to stress the heart a little bit more. Whereas there's a lot more distance between doing leg stuff than the upper body. So then, of course, we've got the bad one over here. This is the infarction or necrosis, right? And we see this. This is not a good sign because that means what's happening to the heart. What's happened to the heart with infarction or necrosis? It's doing what? Yeah, it's not contracting. It's possibly starting to die, right? And especially maybe somewhere around the SA node or something to that effect. Or we're just looking at it going, hey, something in the heart's dying. So you have a Q wave. The Q wave is the Q point is going to dip normally. If you look down here at the bottom, it's going to have a slight dip. But the dip is really minor, right? The S is always going to be the bigger of the two dips. When you look at this, in reality, it doesn't look much different then that action potential curve, if you look at it, does it? Remember we talked about the action potential curve, where you get that point where you get to the actual muscle depolarizing. And then when you look at that S wave, the S wave is the hyperpolarization of the cardiac muscle. And then the T wave is kind of the return to normal polarization. So in reality, the ECG is nothing more than that standard thing that we learned back in Anatomy 1 with the action potentials. It really is. It's just a graphed version of it. Pretty much all the time when you have a patient that's got something abnormal in their ECG, the initial answer is stop therapy, get help, right? But if you're looking at a patient's got a normal, typical EKG, not that big of a deal. Now, do you have to know every single thing about the EKG? No. Do you remember what the question was asking about specifically that maybe I can give a little bit more of a question, or was it something specific that it was asking about on the question? Because I can't really see the Pete, so I don't know what the questions are on it. Okay. So do you have more than one ECG question? That seems odd. I'm gonna have to look into that. There are two. Wow. Okay. Yeah, because the likelihood of us knowing specifics about ECG is a little bit out there. And I may have to just, if they're going to start asking more questions, I may have to hit this harder. So with fibrillation, what's that going to look like? What's fibrillation going to look like on an ECG? Yeah, abnormal. Good. Great answer. Let me see if I can find a left. Here we go. Let me copy this picture over. Back to my document here. Hey, look, it's part of my face. That's fantastic. All right, chat. So this is a heart that's in fibrillation. Yes, it can be. Yes, it can. An ST elevation can indicate a preventricular contraction. Yep. So this is what a heart looks like that's in fibrillation, right? This looks like you've got a 4-year-old scribbling on the EKG, right? At this point, when you see this, what are your options? Well, if you see this and you see it's going this bad, probably the best option would be to do what? If you're in the hospital. Stop treatment first, right? And probably also do what? Call a code. Because especially with ventricular fibrillation like this, there's only one way they're probably going to be able to get it back into cycle, and that's how. Yeah, they may have to do some sort of cardioversion or something to that effect, or do something to put a rhythm, maybe even do something like putting in a, oh my God, pacemaker. There we go. There's the word I'm looking for, because this rhythm is just unhealthy. This is definitely not conducive to human life, right? So when we see something where we've got that fibrillation, so fibrillation is just going to look like a kid scribbling. It's not going to have any clear defined waves. Now you might actually get, if you look here, right in here, we've kind of got an almost normal wave. Almost, right? So what's happening there is the heart's trying to say, okay, you know what? I'm trying to reset myself and go back to normal. And so it kind of slows everything down and tries to get it back in line. And then the heart says, nope, we're going to do what we want anyway. If the patient goes into fibrillation, what's happening to their blood supply? So let's think that I'm in left ventricular fibrillation. So my heart is just shaking back and forth pretty much is what's happening. Is blood getting out to my body? Yeah, blood's decreased going out to my body. So I'm going to start getting necrosis, right? And even they're looking at that somewhat with COVID right now, right? With COVID affecting me, they're saying maybe COVID's more of a blood or a heart disease as well. Because you're talking about, have you guys heard about patients having to go on ECMO? First of all, you guys know what Ecmo is? So ECMO is extracorporeal, right? Oxygenation. So they've got to go in and basically oxygenate the blood for the lungs. So the blood's coming out of the body, it's being oxygenated outside and then pumped back into the body. That means the heart's just not doing its job anymore, right? It can't keep up because of it being diseased. The lungs can't keep up. They can't oxygenate the blood. So same thing here. If we've got ventricular fibrillation and that blood's not getting out there, eventually what the body's going to start doing is shunting off limbs, right? It's going to say, well, you know what? We need the brain, we need the heart, we need the lungs, we need everything in the organs sector. We don't need the hands right now. So we're going to start shunting off those blood vessels out there because I need to live, right? The body's going to go into survival mode. So this is definitely an area where we definitely would stop treatment and say, okay, we need to not do this. We need to get help. And I would honestly, if I'm seeing something as bad as this, I'm definitely calling a code because this is just bad. If your nurse is available, maybe try the nurse first to see if there's something that she knows that this is maybe it leads off too, right? Don't always jump to think that the patient's having problems, right? You're sitting there with the patient and the patient has no shortness of breath. They're not having any issues. And, they're looking whole, hale, healthy. Their oxygen rate's normal. Everything looks normal, but that EKG is going wacky. That's the time that we're going to go, okay, well, maybe it leads off, right? But a patient that's in this ventricular fibrillation, they're going to have symptoms, right? They're going to not look healthy. They're going to be diaphoretic. And they're going to say, I don't feel right. A lot of times they may get that sensation of doom and gloom where like, I feel like I'm going to die, right? Their brain at that point is telling them things are going bad right now. We need to stop it, right? But the primary ones that you're really responsible for knowing what looks like are the ischemic, the entry, and the necrosis. So, I mean, this should tell you automatically, like I said, if you're looking at a heart that's got this kind of rhythm down here, that should automatically tell you that you've got problems you need to stop. What were the answers? Right, exactly. That's right, Gisette. So unless you're in the SICU or in a cardiac care unit, maybe, right? Because cardiac care unit sometimes has them as well. You're not going to have direct access to the EKG. So that's kind of it's the same thing if somebody's got an EEG on, right? Or something to that effect. You're not going to have direct access to it because it's probably going to be up at the nurse's station. So that's going to be one where if in the real world when you're treating, the nurse is going to have to look at that EKG before you start, right? The nurse needs to take a peek at it and see if it's okay for them to have therapy. If the nurse doesn't clear them, then we document the nurse said not cleared for therapy due to cardiac abnormalities, right? Now, let's say that we saw somebody that had this, that has this ventricular fibrillation here. Do we indicate on our note that PTA noted ventricular fibrillation in ECG? Would we put that? What do you think? Yeah, no, I wouldn't, because what does that mean we're doing? So what I said is, if we notice this on the ECG and we stopped therapy, we got the nurse, they took the patient away from us, and we went back to do our documentation, we're like, noted ventricular fibrillation in the ECG, so stop therapy. We're not going to document that because, yeah, that's diagnosing, right? But what could we put? We noticed what? Yeah, notice an abnormal ECG. Exactly. Abnormal heart rate, abnormal heart rhythm, anything to that effect is fair. That just basically says something was up with it. Let the diagnosticians diagnose what the problem is. I don't want to put that in there because that's going to become part of the permanent record. And let's just say for whatever reason that patient files suit against the hospital or whatever it may be, your little note about them having ventricular fibrillations could come back in the end. If you just put there's abnormal, most of us have something abnormal with our heart reading if you look at it every now and then, right? Some of us have little skips in our beat and stuff like that. What would be the next action for that? What were the options? Do you remember? Okay. That was the answer. Was that the right answer, Ian? Yeah. So again, yeah. So that would be what that is that's another instance of, is it an actual PVC or is it an artifact? Right. So if it's just one, like even if you had a fibrillation like this and you have a little blurb of fibrillation, does that mean we stop treatment? No, probably not. Probably what that's doing is you're moving them around and the cables aren't working. Or for whatever reason, when you sat them up, their heart just had a little flutter going on. We're going to wait for it to normalize, keep an eye on the EKG, and then just continue treatment. Right? One incidence of a PVC is not going to be a big thing. Multiple instances of it, yeah, that's going to be a big thing. But again, it could be an artifact. It could also be a true PVC. But one PVC is not going to be, it's not going to kill them, right? Even, having something like AFib, like Jackie has, right? If you looked at her EKG when you went into the room, it's going to be abnormal, right? That's going to look really abnormal to you, but it's normal to her. And I wouldn't be surprised if when you sit her up, if she was the patient, if you sit her up, she throws a PVC. And the thing is if you look at it and you have that one abnormality and it goes back to a normal rate and rhythm, pay attention to it, but continue treatment. Now you start seeing those popping up regularly. Now it's time to contact the nursing, right? I wouldn't contact the physician or emergency response for one single artifact in the actual EKG, right? But you start seeing everything's jacking up all over the place. That's a time to contact them. Does that make sense? Anything else on EKGs that you didn't understand? I know I said hi to Kiana, but I don't know if she heard me because she was still logging in. I'll also say hi to iPhone user. I like iPhone. iPhone is a nice person. Is there anything else on ECGs that you needed to understand? So the main thing with ECGs is understanding this, the what do you call it? Oh, Centali, okay. See, that makes more sense. I didn't think I'd have Apple monitoring my calls. So the main thing, the main idea, this is what I had to look at this because I'm not sure why they're asking so many, because even 2 to me sounds a little bit high. Even for a PT board, honestly, the PTs don't get much more experience with ECGs than we get. And just to let you know, Natalia, I'm also recording it, so it'll be up. I'll post it as soon as we're done as well, in case you missed anything. As far as I was aware through it when I was looking at it, the only thing we really had to understand was what a normal ECG will look like. And if you had a patient going into VFib, what your response would be. But if you have one, like again, if you have somebody throwing a single artifact or something odd once, monitor it, keep an eye out for it, see if it happens again. If it doesn't happen again, move on with treatment. Right? Just a single thing, right? It's the same thing if you get a patient, you're getting a patient out of bed, and all of a sudden they're like, "Oh, my back," and you sit them up, they're like, "Okay, I'm all better." Right? just because you had that one back spasm doesn't mean you're going to stop therapy, although they'd probably try to use that as an excuse to stop therapy. It's the same thing with EKGs. You know, you're not going to necessarily have to stop treatment because you had one little weird thing happen. Anything else on ECGs? All right, so I'll take that as a no, and I will move on to the next topic. Stop share. So the next thing you had asked about was common Ionto meds. And let me bring this up because I have a little tool for everything. Share screen. All right, do you guys remember this from physics? All right, so what were the questions that you were having Ionto that were confusing? Was it asking about the charge and stuff like that, or what was it asking about? Because these are pretty much all the common meds for Ionto and also phonophoresis, honestly. Good, yep. Okay, so that's what I figured. So let's just take a step back and kind of rehash out the Ionto. So with Ionto, you're going to have an active pad and a dispersive pad, right? The dispersive pad is just to complete the circuit. That's all it's going to do. The active pad is the one that you're going to put the medication on. So let's say we're doing acetic acid. We put the medication, the acetic acid, in on the Ionto patch, and then we start connecting the leads. We're always going to connect the same polarity lead as the medication is. So if you have a negative, like acetic acid is a negative, you're going to connect it to the negative lead because the opposites attract, like charges repel. So you want negative going into that pad so it pushes that medication into the body. For the most part, if you look, most of your medications that you're going to do, I mean, it's pretty well evenly split, right? Negative, 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 positive, positive, positive. So I think there's one more negatives there. But a good chunk of the stuff we're going to do, because like I can honestly tell you, I don't remember the last time I've used copper sulfate. I think the only thing positive here I've used anytime recently is lidocaine. Most of the other meds are negative, right? So acetic acid, dexameth, right? Those are going to be our major ones right there. Maybe some salicylates, but you know, if you've got something that's an acid, you already know that's a negative charge. So if it's negative, it goes on the negative side. So let's say I've got a calcification of the tendon up here. And we're going to use some acetic acid to kind of soften that up. So we're going to get our acetic acid. We're going to put it on our patch.
I'm leaving in January.
Oh, yeah, yeah.
I
There's
understand.
paperwork and
Yes.
paperwork, and then there's paperwork.
Yes, and then I'm like,
All right, we're going to mute that. So again, we're doing calcification of maybe something like the bicep tendon, right? So we're going to get our pad. We're going to put our acetic acid on it. We're going to put that pad in place. We're going to put the opposite pad, usually on the opposite side of the body from where we put the primary pad. And then we know that acetic acid is negative. So we're going to take the negative lead, attach it to the pad that's on top. We're going to put the positive lead on the back side so positive can help pull the medication towards that area. And then we'll start treatment. Do you remember what the standard treatment time is for Ionto? Yeah, so the main thing is it's 50 milliamp minutes is usually what most of the time we're going to treat it. So what that says is if we are using 5 milliamps of charge, in order to get to 50 milliamp minutes, we have to do 10 minutes of treatment, right? Because we want to get to 50 milliamp minutes is pretty much the standard treatment for most medications. So whatever you have, that the amperage times the time should pretty much always equal 50, if that makes sense. That's pretty much a blanket rule you can use if they ask you about how long to treat a patient for. For Ionto, they'll say that the patient is receiving 10 milliamps with iontophoresis. How long should they be on iontophoresis for? We want to get to 50 milliamp minutes, so they're going to be on for 5 minutes, right? Usually we're going to be down somewhere around the 2.5 range because that's on average. So yeah, 2.5, we're going to be on for 20 minutes. The more you bump that milliamp up, the greater the chance you have of a negative reaction. So the more powerful you make the charge, the more likely you are to get a burn or irritation under the pad. So the lower you can do that pad, the better. Now, good news is most of the new iontophoresis stuff are, pretty simple. They're plug and play. You don't even have to plug in cables or anything. It's just a little patch that already comes with this area that you put the medicine on. You put the medicine on, you flip the switch to whether it's a negative or a positive med. They slap it on and they go home with it. And then it'll beep and shut off when it's done. And I think those are set to 2.5 milliamps, which will be then about 20 minutes. Is there any of the medications you're not understanding, or does that help at least understand what side to put it on? Okay. Is the cathode the negative pole? Yes. Yes, the cathode is the negative pole. So you're going to put it on the cathode. Cats are negative, right? Don't think about the charges, though, because the anions and the cations are different. The cathode's the negative, the anode is the positive. So I always remembered that the cats are negative, so the negative pole is the cathode. So let's say we had something like we're doing lidocaine for numbing it. Then we're going to put the anode on the pad. Does that make sense? All right. Anything else about these that you're not getting? Are those okay then? That one's a pretty simple one. Now let me get my tablet out here. I know one of the P questions for Anto was asking between 10 and 20 minutes. Yep, that's exactly right. You just are going to do the time to figure out how to get the 50 milliamp minutes. So if you had 10 minutes, you would be doing a charge of 5 milliamps. If you did 20 minutes, it would be 2.5 milliamps. Because whatever it is, charge times time needs to equal 50. Does that make sense? That's the easiest way you can remember it. So charge times time got to equal 50. So if you've got a charge, unless they specify otherwise, right? And sometimes if the PT specifies otherwise, that throws everything out the window. But most of the PTs, it's kind of like when we talked about ultrasound, right? That everyone does 1.8 watts per centimeter squared. Why do we do that? Well, that's just because what everyone's done for forever. And so, it just kind of sticks. Most PTs are still going to stick with the 50 milliamp minutes for treatment time. But yeah, if the question says something like the patient was supposed to get 100 milliamp minutes, well, then you've got to change your math up a little bit. That one good? Bye, Natalia. All right, so now I want to we're going to talk about the diamond. Screen mirroring. It's my first time trying the iPad thing here, so let's see how it works. All right, so this is that lovely old diamond. Can everyone see it? Where's my chat? All right, so we've got the diamond brought up here. My chat hiding here. There's my chat. So with this one, again, the majority of the questions are going to be about which muscles are tight and which muscles are, you know, either stretch weak or they're tight and need stretch. You know, so if they're stretch weak, we're going to strengthen them. If they're tight, we're going to stretch them. And most of the times it's going to deal with that pelvic tilt, right? So we've got our little diamond here and we got our primary group of muscles, right? We have our trunk extensors, our hip extensors, our hip flexors, and our trunk flexors. Now, unfortunately, or not unfortunately, but for you guys, I usually group them in groups, but you should be able to remember that the rectus abdominis is part of the trunk flexors, that the erector spinae is part of the trunk extensors. You guys should be pretty well at doing that at this point. So if the patient goes into anterior pelvic tilt, right? So they're going down with that ASIS because, you know, here's our ASIS, here's our PSIS. If they're going into that anterior pelvic tilt, this is going to come down, right? So the ASIS is going to drop down. That means this muscle is going to get short. If that muscle gets short, the muscle diagonal from it is going to get short. That means the other two muscles then are going to get long. And so if somebody's stuck in anterior pelvic tilt, right, our hip flexors are going to be tight and our trunk extensors are going to be tight. So what are we going to want to do to them? If they're tight, we're going to stretch it. Yep. Now that means that the other muscles are going to be lengthened. If they stay lengthened for a long period of time, they will become stretch weak. But it's still not a bad idea to strengthen them to help pull those other areas back into alignment, right? So, you know, if we had a person that's stuck in anterior tilt, you know, maybe our iliopsoas is going to be tight. Maybe our rectus femoris is going to be tight. Our erector spinae is going to be tight. And then our hamstrings and our rectus abdominis are going to be kind of stretch weak. They're going to be loose. So we're going to have to strengthen them a little bit. So let me get my little eraser here. Oh no, that's not how I want to do it. Undo. Can I just erase one thing? No, I can't. It doesn't allow me to do that. Of course not. So let's say that instead of being in anterior pelvic tilt, I'm now in posterior pelvic tilt. Right, so now I'm in posterior pelvic tilt. Which are my groups that are going to be tight? So I'm stuck in posterior pelvic tilt, which almost never happens. Trunk flexors and hip extensors, good, right? And so that means then the opposite two are going to be stretch weak or stretched out. Excuse me. So those are the ones then we're going to strengthen along the way. Does that make sense? Are there any questions on so that's kind of the anterior and posterior pelvic tilt. Do you want to go over the lateral diamond as well? Okay, so let me clear my board here. Never used this form of whiteboard, so it's kind of interesting to try. I'm just using my iPad with my iPad pencil and drawing on it. If you had to pick between stretching or strengthening, which one would be better? Well, it depends upon what the question's talking about, right? So if I'm in posterior pelvic tilt, let's say I'm in that posterior pelvic tilt, right? So I'm in posterior pelvic tilt. If the muscle is tight or it's shortened, I'm going to stretch it because it's already got hypertrophy because it's kind of tight and tightening up. Are we going to strengthen it long-term? Probably, right? Even if let's say that I'm stuck in posterior pelvic tilt, so my abs are tight. I want to get them stretched out, so I'm going to have them laying across the ball, leaning back, stretching out those whole abs, right? I'm still probably going to strengthen a little bit of that area long-term, not right off the bat, because I want to kind of get those muscles in alignment. But first thing I'm going to do is stretch them because I've got to get them out of that hypertrophic, that tightness, so they don't become fibrotic. Because if they stay that nasty tightness the whole time, eventually they could go fibrotic on me, and then no amount of stretching is going to help them. So stretching is going to be the best answer for a muscle that is the shortened side of it. Strengthening is going to be the better answer for one that is on the lengthened side of it. So we have right, left. And we have you had to pick between. Well, what if it gives you both options? Well, then you're going to pick the one that's appropriate for the diamond. So again, if the muscle, let's say they're talking about, again, I'm in posterior pelvic tilt, so my abs are tight. And it says, what would you want to do to the rectus abdominis in a person that's stuck in posterior pelvic tilt? I'd want to stretch it. Okay. So let's say it gave me my trunk flexors, and my trunk flexors are tight from being in posterior pelvic tilt. You're going to pick stretching for that because those muscles are already short. So I need to lengthen them out to get them to appropriate length. Because no amount, if I strengthen them, all that's going to do is reinforce that tightness, right? You've done this when you go to the gym, right? You go work out really hard. Let's say you did a leg day. And so you really tore at it with leg day. And then you go sit on a toilet. And all of a sudden you're like, oh, yeah, I can't get up. Well, what happened is those muscles got tight from you doing leg day, and you reinforced it by exercising them pretty hard. And now they're not able to obtain the right length in order for you to stand up. They may not even be able to activate because your legs are just dead. Does that help make sense? So if they're tight, you're going to stretch. If they're lengthened, you're going to strengthen. That's pretty much what that's pretty much the golden rule. If they're long, strengthen them. If they're short, stretch them. Okay. If you find the question, I can always take a look at it with you too. So this is looking at the diamond now laterally, right? So we had the anterior posterior diamond. This is now looking at that right and left diamond. So the control of the pelvic tilt. So the main muscles that are going to control that pelvic tilt are going to be the QLs, quadratus lumborum, and then the glute medius. Now, obviously, all of those hip abductors are going to help add to that. So even TFL is going to help with that, right? And even a little bit of glute min. But glute medius is going to be your main one. So if a patient's got lateral tilt to one side, let's say I've got lateral tilt to the right, right? So my pelvis is tilted like this. If my pelvis is tilted like this, right? This side over here This glute med is going to become short. This QL is going to become short. This one's going to get long. This one's going to get long. So this is where it gets a little different from the anterior posterior one, because now we're looking at right versus left. And so the diamond changes a little bit. So if I had that right inferior pelvic tilt going on, I'm going to want to stretch my right glute med and my left QL while I strengthen the opposite two. Because I'm going to want to strengthen the ones that are elongated and stretch the ones that are tight. Does that make sense for the lateral aspect, at least? The only reason this is a little bit more difficult is because you've got a QL and a glute med on both sides. Yep, sure, no problem. So again, I'm standing and I've got a right inferior pelvic tilt. So that right pelvic crest is now kind of almost going down towards the ground. If that's true, my right glute med is going to shorten up. It's going to get the short end of the stick. Opposite to that, then the diamond is going to be my left QL. So those two, because they're going to become my tight ones, those are the ones I'm going to stretch. And then my ones that get longer, because they're being lengthened out, are my left glute med and my right QL. So we're going to try to strengthen those out. What am I probably, in this case here with this diamond, what am I probably going to have when I walk? What type of a sign? Yeah, probably have a slight Trendelenburg sign, right? Now, this may not be a neurological Trendelenburg where it's a nerve-related one. This just may be a tight versus loose Trendelenburg, right? So that would be one where we're going to keep an eye on that. So knowing that my left glute med is my weak muscle, what side is going to drop? Very good, the right side. Exactly, the opposite side from the weak side. So that can give you an idea that maybe you've got a person that's got a right Trendelenburg. Well, that's going to tell you that you need to strengthen that left glute med and probably the right QL as well a little bit to help keep that pelvis level. Now, how much change in verticality is normal during gait? Do you remember that? Yeah, 2 inches. So you've got 2 inches of going up and down. If that's there, that's fine. You know, they get that 6-inch drop on that pelvis, then yeah, we've got a Trendelenburg sign going on, and we definitely want to work with it. Does that help with the pelvic diamonds? I hope it does. Like I said, if you have a specific question, I can always look at that specific question too. I wish they gave us access to the questions so I could actually see them. Maybe I'll just have to buy one day and just look through it. Are we okay on the pelvis overall at this point? Do you think? Maybe? All right. Yeah. I like the eraser. It's fun. I'm like a kid with a new toy. I had another instructor tell me about this, and I thought this was the greatest thing since sliced bread. All right, let's stop sharing. Okay, so that hits that, that hits that. Okay, so synergy patterns. What kind of questions did you have on synergy patterns? That was way close. First of all, what should you know about synergy patterns? If you've got a synergy pattern, it probably is what? Is that normal or abnormal? Or how about this? Do we have normal synergy patterns? You have no idea about patterns. Okay. Do we have normal synergy patterns? Yeah, right? PNF is a normal synergy pattern, right? PNF is nothing more than a synergistic pattern. The muscles working together to get to a certain point. Even doing a bicep curl, you've got a synergy pattern going on because your biceps are contracting while your triceps are relaxing. So that is going to be synergistic movement. But most of the time when we talk about synergy patterns in physical therapy, we're usually talking about them in relation to stroke patients. And we're talking about abnormal synergy patterns. Is that what the questions you ran into about them were about? Yep. So that's usually what they're going to talk about. So let me screen share here again. Come down here. Definitely make that a little bit bigger because that's really tiny. So this is literally right out of your rehab book that I just kind of copied this section out of it. So it kind of covers what an idea of a synergy pattern. So synergy patterns are going to come up in the stages of motor recovery. So it's about positioning, right? So let's say they have an abnormal synergy pattern. Do we want to promote that pattern? Typically not. Now, let's say that we've got here's a time where we might promote a synergy pattern. Tenonesis grip, right? That is actually a synergistic pattern, right? So where we let the finger flexors contract so that when they do some wrist extension, they can grab stuff. Technically, that's a synergistic pattern. So that one we definitely want to promote, especially if OT or the hand therapy says they need that patient to have that synergistic pattern. But for the most part, when a patient has an abnormal synergy, we don't want to promote it. It's the same thing like with a child, right? Let's talk about like AT&R. What's AT&R help with in a baby? It starts them getting ready to do what? Roll. Let's say that AT&R hasn't integrated. So they're not integrating it. So they're not getting it. We don't want to continue to promote that baby not to get the AT&R pattern because then they will never roll over. Same idea with the stroke. So the two main patterns we're going to have are flexion synergy and extension synergy patterns. That goes right back to that decorticate versus decerebrate posturing, even back with TBIs and stuff like that, right? Ouch, that was toe. So when we have a flexion synergy pattern, the patient's going to have scapular retraction with elevation or hyperextension, shoulder abduction, external rotation, elbow flexion, forearm supination, wrist and finger flexion, right? Hip flexion. So they're going to kind of start curling up like this, right? So if they're in that pattern, how are you going to want to position them? If they're in a flexion synergy pattern, you're going to probably want to position them in what other pattern? Yeah, the opposite. Exactly. You're going to want to get them out of that habit. So you're going to want to move them more into extension or more into that extension synergy pattern. Right? So if I'm way retracted back like this, when you lay me down, how are you probably going to want to put my arm? If my scapula is retracted, you probably want to do what to me? Protract it and kind of get me reaching forward. So let's say I'm stuck in flexion synergy pattern. What position is going to promote me to lie in a position that will allow you to kind of move my arm into extension and scapular protraction and a little bit of internal rotation. Is supine going to? Let's think about it. If I'm in supine, yeah, I'm going to want to go sideline. Exactly. Sidelines kind of, if a person's got flexion synergy, I'm probably going to want to put them in sideline because that's going to be the easiest way to move them into extension synergy. But if I've got flexion synergy or got extension synergy patterns, well, then I may want to do either prone or supine in order to get them into that kind of flexion synergy pattern. So I want to go to the kind of opposite direction in order to get them out of that abnormal synergistic pattern. So when it's talking about synergy, it's literally meaning if I do one thing, what do I look like, right? What happens? So, and if you think about it, looking at that flexion synergy pattern, it kind of looks like you're going almost into that kind of fetal positioning, right? The most common area you're going to see of that, of when you're in a flexion synergy pattern, is going to be elbow flexion and hip flexion. Those are going to be the most common things you're going to see in that flexion pattern. And so if you position them lying down, you're going to want to put them in elbow extension and hip extension. And then if you look over at extension synergy, shoulder adduction is most common, forearm pronation, and then hip adduction, knee extension and ankle plantar flexion. So you're going to want to position me that you get me out of those patterns. Now, sometimes, and again, this is not for the boards, but sometimes when we're dealing with somebody that's going to be, that's using specific forms of neuro reeducation, in the initial stroke phase, they may promote those synergy patterns while the patient's in the inpatient acute phase, because they may be able to use those to help them get out of bed. But they're eventually going to start getting that patient out of those synergistic patterns and get them back into a normal function. Because let's think about it. If I'm in a flexion synergy pattern like this, am I going to be able to use a walker? Not really, right? So that's going to be a problem. I'm never going to get this patient to walk. So I've got to get them out of that synergistic pattern so that they can actually walk. So the idea with synergy patterns is knowing whether they're in a flexion or extension synergy pattern, and then positioning them in the opposite. Are you going to have to remember all of these? I doubt the question is asking you to remember all of them, but it's just kind of thinking about what's the best position to put them in if they're in these patterns. Does that at least help make you understand what the synergistic patterns are? What's causing them to be that way? How about that? It seems weird they'd say 0 degrees of rotation, but I guess I can understand why they're going to say 0 degrees of rotation. So why would we do 0 degrees of rotation? What's that going to put them in alignment for? Walking. Because think about it, if I do a ton of rotation, if I put them in to that internal rotation, then my foot's going to be kind of facing all wonky when I get them up to walk. So the long-term goal of any of these patterns is getting them up and moving. And so I'd have to, the question should have been worded a little bit better, because it probably should have talked about where they're at in the rehabilitation phase, because maybe in that acute phase, I may actually have put them in internal rotation, because I may want to really kind of negatively affect it. Position of the MTP. Wow. Well, the main thing is with that, the main thing is if the patient's in a flexion synergy, what are the hands and feet going to look like? Let's say I'm in a flexion synergy pattern. I'm going to look like, I'll get you my little pretty and your dog too. right? I'm going to be all curled up and gnarled up. You like the voice? That was fantastic, right? It's perfect for Halloween. So if I'm in this pattern, what are you going to want to do to all my joints? Extend them out, right? So now let's say I'm in extension pattern and all my fingers, well, actually, if you look at both of them, they kind of go with finger flexion, don't they? So both of them end up in finger flexed, but the toes are the different part, right? So when it says toe dorsiflexion, really they're saying the toes are going into what? Extension, right? Yeah. And sometimes I wish we just used, I actually kind of prefer toe dorsiflexion and toe plantar flexion because it kind of keeps in alignment with the rest of the ankle. So the toes are really the only different one. And I bet you that's probably why they threw that question in there, because the hands stay the same, the toes change. And I'm guessing that's probably why they probably brought something about the MTP, because everyone's going to be thinking, oh, well, the hands stay the same, so the feet got to stay the same. Well, the feet don't stay the same. So if I got a patient that's stuck in a flexion synergy pattern and my toes are in dorsiflexion, I'm going to want to move them into plantar flexion. What devices could we use? Let's say even for the hands and the feet, what could we put them on in order to get them into the proper positioning? What could we have ordered for them? Orthotics, right? We could have some splints ordered, right? We could maybe have a cock-up splint or something, an extension splint, a dynamic splint. I don't know. I don't do any splinting. That's beyond my abilities and skills. Give me an off-the-rack orthotic and I got it. But you asked me to make a splint. I haven't made a splint since school. And even then, the only time we made splints, we're like, hey, we've got splint material. Let's play with it. We didn't actually have specific training on splints. Does that make sense, though, about synergy patterns? I can see where they were going with that 0 degrees of rotation, Ian. I would have liked the question to be a little bit more descriptive, I think, if I was writing it. But, I mean, their logic is solid, because what they're trying to say is the patient's got to get up to walk. Now, let's say we have a patient that we know is not going to recover completely from their stroke. So again, this is taken a little bit further here. So we know that maybe this patient, the stroke is that bad that the likelihood of them fully recovering from the stroke is pretty low. Are we going to be so worried about the fingers flexing? Probably not. The toes, yes, because the toes are going to help, again, are going to help promote gait. But the fingers probably not as much, because we may, again, want them to have that tenodesis grip. And remember, it's not tendonesis, it's tenodesis. Those are two different things. Does that help a little bit with synergies? Kiana, did you have any questions about synergies? Or are you just here for the ride? All right, so let's stop share here. And last thing that Gisette had asked about was inpatient versus acute versus outpatient. I think she had said, let me see what it said here. Clarify acute, subacute, and inpatient. Okay. So with this question about, are you talking about when to send a patient to specific places, or what was the question about that you had, that you were questioning? Or what the difference is between them, or? The differences? Okay. So when I think subacute versus inpatient, if I start thinking about subacute, I automatically throw in the subacute rehab, and I start thinking about TCUs or SNFs. When you're talking true inpatient therapy, that means that patient is in the acute phase. That means they're in their first 2 weeks of whatever the injury is, whether it's a heart attack, stroke, total knee replacement, whatever it is, they're in that first 2 week phase. So that's when they're in that true inpatient phase. So inpatient is going to be physically, when they talk inpatient, they're talking in the hospital. And when you think hospital, not like, like the TAM facility or anything like that, or, they're talking truly being, right. So they're talking about truly being in the hospital. So now when we go from, let me just bring up my whiteboard here. That'll probably help a little bit. I want to bring up the whiteboard on the iPad because that was nice to write with. Give me a second here. So iPhone, iPad, screen mirroring. Yeah, pretty much. I mean, acute and inpatient are used pretty interchangeably. It's where you get to that subacute that things start getting a little hinky. But you can also have inpatient. So whenever you call something inpatient, that means the patient is confined to the location. Because you theoretically could even call like a transitional care unit an inpatient subacute unit. Because what inpatient means is they never go home, right? So if I have inpatient, I'm stuck there. That means all of their care is being delivered at that location. So if I have inpatient, I could have inpatient acute. I could have inpatient rehab. I could have inpatient subacute or SNF, basically. So inpatient means the patient is never leaving the facility. They don't get to go home for any period of time. They don't get to do anything like that. They are physically stuck there. That means who manages all their medications when they're in an inpatient facility? Nursing, right? Nursing is going to manage all their medications. We're going to manage all their therapy. They're not going to, usually they're going to have more therapy than they would have at the outpatient setting, right? So in that acute, again, that inpatient acute usually is the first 1 to 2 weeks. It can be with something like a total knee replacement. It may be the first 3 days. LTAC technically, so LTAC would kind of be here. LTAC kind of splits that acute versus rehab area. And really what it is, I don't even want to put it there. Actually, let me rethink that. Let me erase that. I kind of want to put LTAC up here. Because if you're talking LTAC, what's that probably tell you about the patient? Are they likely to get better? So LTAC, long-term acute care. Yeah, my boarding pass came in. Yeah, no, they're likely to not get better, right? So a lot of their LTAC patients are going to be your terminal end of life patients or your patients that are in comas. So what they are is they still need full-time nursing care, but they don't need the level of full-time nursing care that maybe somebody in the ICU might need. right? So they still need, they're responsible. They need nursing to take care of, all of the urinary care, all their incontinent care, everything like that. But they're no longer in that first 1 to 2 weeks of care. And they know that they're going to need that long-term care or that acute care for a long-term period of time. So that's where the kind of LTAC falls. And then remember, once we leave the acute care, that's where we have to decide where they're going to go. So we're going to decide whether they go up here to LTAC, to rehab, down here to subacute, or even better for them would be to go home, right? So we need to decide if the patient is safe to go to outpatient. If the patient is not safe to go outpatient, then they stay inpatient in either a rehab or a subacute facility. In order to qualify for rehab based upon Medicare guidelines, do you remember what the Medicare guidelines are saying about that? They have to be able to tolerate 3 hours of rehab. Yep. And the other thing is with 2 disciplines. So meaning they have to have PT and OT, PT and speech, OT and speech, OT and respiratory, something along those lines. They have to have the ability to have 2 different distinct therapies. So let's say you have a patient that's in an inpatient facility and they are in a coma. Would they be appropriate for an inpatient rehab? Yeah, probably most appropriate for an LTAC, right? Why do you think they'll take them out of rehab facility? Just to get what? Money. Yeah, that's pretty much it. They're not going to tolerate that rehab, right? They're not going to tolerate 3 hours of rehab, but you'll see it all the time, unfortunately. A case manager will sell that, oh, well, we can take that patient that's, on the RLA scale of 1, we'll be doing great with them. The patient's basically drooling all over the place and can't get out of bed. They're not going to tolerate 3 hours of rehab, and that makes our jobs a lot harder, right? And it really helps if they explain to these patients when they're being discharged that these 3 hours are non-negotiable. Because from Medicare standpoint, if the patient can't get 3 hours of therapy, guess what they're going to do? I kick them out of rehab. And Medicare is going to say, I'm no longer going to pay for this, so you have to find somewhere else to send the patient. And the sad part about that often happens is they'll get to that point and they'll send the patient back to the hospital. And then the patient's right back into that kind of vicious cycle of where they're going. And then they'll send them back out to the rehab. And they'll send them back to the hospital. Yeah, right. How does that work out? It doesn't work out very well. I mean, ideally, if you're in the rehab setting, you'd ideally get about an hour and a half therapy in the morning and about an hour and a half therapy in the afternoon. That works out best for them. So most rehab patients are going to be BID patients. Some tolerate 3 full hours in the morning and they're done for the day. If they can do it, fantastic. But it's pretty rare. At that subacute or that sniff phase, that's where we kind of get, that the amount of therapy they get varies. They can get as little as none, right? Because they could be in that nursing home and never get therapy. And a lot of these sniffs or these LTACs, or not LTACs, TCUs is what their new fancy term is. A lot of the new TCUs are advertising themselves as rehab units because they do rehab and they maybe do 2 hours, like you said, but that doesn't officially qualify them for a rehab status under Medicare. But here's the deal. If the patient can get 2 hours of therapy, if you know that, say you've got the Gisette Rehab Facility and they guarantee patients 2 hours of therapy, I'd rather send them to your facility than sending them to a facility where I may not get any therapy. So it's still, I would still rather send them somewhere that's going to give them 2 hours therapy than anything. So let me erase this. This is so cool. Yeah. I need a bigger eraser. All right, so now we're going to talk outpatient, right? So now the patient is safe enough to go home and they're safe enough now to manage their own medications, right? Obviously, the best place for outpatient is just purely home, right? And maybe when we go home, we can, let me erase this because that's a little too far over. I want to give myself some space here. So I can send them home. And when I send them home, I have a couple options, right? I can send them home with home health. Why is this not right? There we go. I can send them home with outpatient PT. Obviously, the worst would be no therapy, right? But if the patient's, you know, like a superstar rock star and they've done all their therapy in the hospital, they're up and walking, they're walking 1,000 feet every time you get them out of bed, they're pretty loose and limber and they're sticking to their home exercise program, well, maybe they're good for no therapy. But those unicorns rarely exist. Why would you send them home with home health instead of outpatient PT? What would probably be the reason why we do that? If they can't do what? What would be the ideal reason to send them home with home health? If they can't drive, right? They have no ability to leave their home to go get therapy, then home health is the best option. Outpatient is always going to be kind of our best option in general. Yeah, sub-acute rehab does 2 hours. Yep, that's, and again, technically, they're technically classified as a transitional care, not a pure rehab. But don't argue that with them. They'll fight you on it. So, you know, if I send them home and they can't drive, well, then I'm going to send them home with home health. I can also send them home, maybe if they have the ability to drive, then I have my two options. I can either send them home with outpatient therapy or send them home with outpatient rehab. And I think Summerlin and Mountain View are the only two facilities I know in our area that have outpatient rehab. And what that literally means is they go home, but for 3 hours a day, they come into the clinic to receive therapy. Excuse me. So maybe they stay at home for the night, they manage all their medications, and then maybe from 11 to 2 o'clock or something like that, they come into the hospital and they receive intensive 3-hour therapy. Man, a patient can do that. That's ideal. Think about how much better those patients will get because they're getting intensive 3 hours of therapy. That's pretty good. A lot of times the VA may approve that if they're going to a VA hospital like the one up on Nellis. Right? Send them in for those 3 hours. As long as it's usually within the VA system, the VA will approve pretty much anything. But once you get outside the VA system, that's where they start fighting you on stuff, which is kind of silly. Patient choice is not really the best outside of that VA system. So the difference between outpatient and outpatient rehab is just really the frequency. Right? If they're in outpatient rehab, they're going to have therapy 3 hours a day. If they're in outpatient physical therapy, maybe they're going to be seen 2 to 3 times a week, and usually for about an hour. So when you're looking at it, you know, inpatient means patients in the hospital, and then you're dividing between whether it's an acute patient inpatient, a rehab inpatient, or a subacute inpatient. And then this is kind of the division out for outpatient going home. Does that make sense? Is there anything else you can think of you'd like covered? Kiana, did you have anything you wanted to talk about, or are you just along for the ride? Along for the ride, okay. Anything else you guys can think about? All right, well, I'll stop recording here. The repeat is typically harder, yeah. Typically. It's a little bit, I'm gonna say probably 10 to 15% harder. Just because, so the difference between the PEAT and the repeat is, you know, the PEAT is questions that weren't quite good enough to make it on the boards, but were good enough to set you up to prep for the boards. The repeat are all retired PEAT or retired board questions that have gone through, I don't know, let's say it's 1,000 cycles. They've been seen on 1,000 different tests. So now they're retired. And now those go to the repeat group. Now everyone gets the same repeat. It's not like it is for the boards where everyone kind of gets a different test, right? I want to say there's something like 175,000 different questions in the actual test bank for the actual boards. So it's very rare that people get a lot of questions that are similar. Now, can that happen? Sure, there can be. They may have. I think it's like out of those 100 and some odd thousand questions, they have 150 what they call forms, and the forms are the groupings of the questions. Is it possible that Gisette can get the same form as Ian? Sure, it's possible, but it's not likely. They'll look similar to the PEAT. You know, if you're already over 600, I wouldn't stress too much thinking about it being that much harder, because at that point you're answering PEAT questions pretty well. Just go into it like you normally went into the last one, and you'll do okay. When I say harder, it just means that they're going to have more questions about stuff like musculoskeletal specific questions, you know, about which nerve innervates this muscle, or what happens if the patient has a nerve cut to this muscle. They're not going to be, you know, it's not like they're going to ask you a ton more EKG questions or questions about diagnosing problems and stuff like that. It's still going to stay within the PTA wheelhouse. Anything else? No problem. Hey, that's what I'm here for. If anything comes up between now and whatever, please, that's what I'm here for. I know you guys are spread out in October. I thought it was just going to be one date, but I know that because of social distancing, I think I've even seen that somebody, I don't know if I was reading from you guys' cohort, if it's somebody that's retesting, they're not testing till November. That was the earliest they could get somebody in. So, you know, if anything comes up, please just shoot me a message. I'll take, you know, even if it's at 8 o'clock at night, I'd rather answer the question that way it gets answered than not. All right, I'll stop recording here.